Sticking with pre-excitation, LGL syndrome is another. How does it relate to WPW and how is it distinct? They both involve a rapid heart's electrical system, right?
You're right, they both involve pre-excitation, where the ventricles activate earlier than normal, but the mechanism is fundamentally different. Lone Ganong-Levine, or LGL syndrome, is also a ventricular pre-excitation syndrome, but it's characterized by what's called enhanced AV nodal conduction. This means the electrical signal travels faster than normal through the AV node itself, rather than bypassing it entirely, like in WPW. LGL was initially reported in 1938 and was first thought to be just a variant of WPW. But in 1952, Lone, Ganong, and Levine provided a more detailed description, establishing it as its own distinct entity.
What causes this enhanced conduction? Is it also an extra pathway or something else entirely?
The exact cause for LGL is still considered ambiguous, not fully understood across all cases. It has been linked to accessory pathways, but different ones than in WPW, like the James or Palladino fiber, may be located between the SA and AV nodes, or the Breschenbecker fiber between the SA node and his bundle. It's also been attributed to congenital AV node hypoplasia, an underdeveloped AV node that conducts unusually fast. However, current research hasn't pinpointed a single common accessory pathway for all LGL cases, suggesting varied underlying mechanisms.
Who tends to get LGL syndrome and what are the symptoms they typically experience?
LGL syndrome is observed to be more common in females, particularly those over 30. Patients commonly complain of symptoms related to a fast heart rate, such as tachycardia, chest pain, episodes of syncope, and palpitations. In some cases, more severe arrhythmias can occur, including AFib, atrial flutter, ventricular fibrillation, or even cardiac arrest, though these severe outcomes are quite rare with LGL.
What sets LGL's ECG apart from WPW, given they both involve pre-excitation and a short PR interval? How can we tell them apart on a tracing?
This is the absolute key distinguishing factor on the ECG. In sinus rhythm, LGL syndrome also shows supraventricular tachycardias and a short PR interval, less than 120 milliseconds. But crucially, unlike WPW, LGL syndrome has a normal QRS complex, and most importantly, no delta wave.
No delta wave. That's the key.
Exactly.
Yeah.
The absence of that characteristic slurred upstroke at the beginning of the QRS is what differentiates it from WPW. Secondary arrhythmias may also be seen. Electrophysiologic studies can help reveal pathways, if present, and assess conduction properties.
Are the diagnostic criteria as clear-cut as WPW's, or are they a bit more nuanced for LGL?
They are a bit more nuanced and maybe arbitrary sometimes, as the classic ECG findings aren't always present. The proposed ECG criteria are indeed a short PR interval, 120 meters, normal QRS complex, 120 meters, and the absence of a delta wave. However, electrophysiologic criteria have also been suggested. These include an interval, atria to his bundle conduction time, of 60 meters or less, maintaining 1.1 AV conduction during fast atrial pacing, and limited interval prolongation during pacing. These help identify that enhanced conduction property.
What's the primary differential diagnosis, and how is LGL syndrome typically treated?
The main differential diagnosis for LGL syndrome is, predictably, Wolff-Parkinson-White syndrome, because of that shared short PR interval. Treatment commonly involves pharmacotherapy, typically beta blockers and antiarrhythmic drugs, to control symptoms. Catheter ablation can be used, but only if a specific accessory pathway is identified. While it can rarely lead to ventricular fibrillation and sudden death, this is very uncommon, making the overall prognosis for LGL syndrome generally considered quite good.